കേൾക്കുന്നുണ്ടോ?
So good afternoon, everyone. Can you hear me?
Yes.
I was just waiting for some more to join, but looks like we have only few participants today. I hope they join a little later. I think Sridevi will introduce Dr. Sunil, who will do the didactic today. Sridevi?
Hi everyone. Nice to meet you again after a break. I was participating in the last two equations, and it's my happiest privilege to introduce Dr. Sunil, who is now our colleague. So Dr. Sunil was working with TIPS for quite a long time. Then he took a break from us and joined back again as the additional director of TIPS few weeks back. And he's one of the students who joined Dr. Rajgopal in the initial time when palliative care started in Kerala. So it's our privilege to be his colleague. Sir, welcome to the eco session for your presentation.
Thanks, Sridevi. Shall we start with it?
So we will start the didactic, sir. Yeah.
So before going into visceral pain as such, I will give you some general features about visceral pain. The two salient features of visceral pain. One is visceral pain is poorly localized. It is because viscera is poorly innervated compared to the somatic structures. So it is poorly localized. And the other one is visceral pain is usually can be referred to somewhere. So this is because the afferents from the viscera and the somatic structures can be converged to the same spinal segment, and when it reaches the higher brain centers, the brain interprets this visceral afferent as somatic afferent. So the liver pain can be referred to the shoulder. So these are the two general points about visceral pain. One is poorly localized and the other one is referred pain. Now I am going to the pain due to increased intracranial pressure. So the intracranial pressure means it is the total pressure exerted by brain, blood and CSF in the intracranial wall. Normally it is about 10 to 15 millimeters of mercury for adults. There is a hypothesis about intracranial pressure by Monroe Getty, who states that the sum of the intracranial volume, that is the volume occupied by brain, blood and CSF, is constant. And if there is any increase in any one of these components, there should be corresponding decrease in the other components. Otherwise, the pressure inside the cranium will increase. This will cause the increased intracranial pressure. So, is the usual causes of increased intracranial pressure. And as I told, it can be due to increased brain volume. So, it may be an intracranial space of fixed pain lesion or maybe cerebral edema. There are many causes of this. Then it may be due to increased CSF volume as well as increased blood volume. Brain as such is not a pain sensitive structure, but there are some structures which are pain sensitive. These are meningeal arteries, proximal portions of cerebral arteries, dura at the base of brain, venous sinuses, cranial nerve 5, 7, 9, 10, and cranial nerve, cervical nerves first, second, and third. So these are the pain sensitive structures in the brain. So in the if the intracranial pressure, sometimes the intracranial pressure may be normal, but sorry, when the due to tumor or anything else, the when there is a traction, it can cause pain, but the intracranial pressure may be normal. For example, in the normal circumstances, if you do Valsalva maneuver, it can increase the intracranial pressure, but it will not cause pain. And when the structures or the masses which distorts dura or other pain sensitive structures, it can cause headache, but the intracranial pressure may be normal. Symptoms of increased ICP are altered state of consciousness, headache, nausea and vomiting, papilledema, and focal signs. The features of headache usually are it is diffuse, more intense in supine position, and immediately after awakening. It is worsened by head movement, cough, and anything which causes increased intracranial pressure like Valsalva maneuver. So inside the brain, because of increase in the cranial pressure, there will be edema, and the edema due to tumors are supposed to be due to it is due to the loss of osmotically active substances into the brain interstitial space. It is mainly the albumin, and it is because of the disruption of blood-brain barrier due to the malignancy. So two mechanisms are described in connection with brain edema. One is vasogenic edema and the other one is cytotoxic edema. Vasogenic edema, which I have described earlier, it is due to increased vascular permeability due to the damage of blood-brain barrier. And the other one is cytotoxic edema, which is because of the cell death, and it causes sodium to accumulate inside the cell, which imbibe water into the cell, which causes cell swelling. So these are the two mechanisms which causes brain edema in increased intracranial pressure. So the treatment described one is positioning, that is the patient should be kept, the head should be kept 30 degrees above heart, which will allow the venous return, which will allow the good venous return. And other things which are used to decrease the increase in the current pressure are hypertonic solutions like hypertonic saline and mannitol. This works essentially by removing water from brain parenchyma. And it is said that it is not useful when blood-brain barrier is not intact. And also should be careful that we should not use it more than 3 to 4 days, because after 3-4 days, this hypertonic solutions like saline or mannitol, it can go into the brain interstitium and it will reverse the process. That is, instead of sucking the fluid from the brain into the vascular compartment, now after 3-4 days, the brain will start sucking fluid from the vascular compartment. So it should not be used more than 3-4 days. The dosage of mannitol is 1 gram per kilogram, that followed by 0.25 gram per kilogram every 6 to 8 hours. And it is contraindicated in patients with congestive cardiac failure or patients with renal failure. The mainstay of increased intracranial pressure treatment in malignancy is corticosteroids, and the choice is dexamethasone. It decreases the outflow of blood components from the capillary bed, and this is because the damaged blood-brain barrier was the cause, and the dexamethasone will fill in the gaps so that there will be less outflow of blood components from capillary bed into the brain tissue. And it has no action on water content of brain. It is not like mannitol or hypertonic saline. And it is said that the ICP, that is reduction in the intracranial pressure, is seen only after 48 to 78 hours. But the clinical improvement can be seen within the first 24 hours. So it is useful that we can use corticosteroids like dexamethasone in increased intracranial pressure. There is no consensus on the dosage of dexamethasone, but usually used the dosage varies from 16 milligram to 96 milligram per day according to the circumstances. So that's about increased intracranial pressure. And the colicky pain of next is colicky pain of intestinal obstruction. So we need to revisit the physiology of peristalsis, and it is a reflex that is stimulated or initiated by stretch of gut content, and it occurs in all parts of GAT from esophagus to rectum. Peristalsis has two components. One is the contraction, and the other one is relaxation. Contraction is mediated by acetylcholine, whereas relaxation is by vasoactive intestinal polypeptide. And both these receptors can be modulated by endogenous opioids. So it is important to note that exogenous opioids can inhibit peristalsis. So exogenous opioids, we use many opioids daily. So it can inhibit peristalsis, and also anticholinergic can inhibit peristalsis. So the mechanism of colic in intestinal obstruction is when there is a blockage, there will be pooling of gastric contents, and this gastric contents will distend the intestine, which will stimulate peristalsis, and the intestine will try hard to remove the obstruction by increasing the peristalsis, and this leads to colicky pain. So the colicky pain of intestinal obstruction can be treated like opioid analgesic, as per WHO analgesic ladder, is the recommended treatment, and it also says that anticholinergics to be added to opioids if opioids alone fails to give effective pain relief. So opioids are the mainstay of treatment even in colicky pain of intestinal obstruction, and anticholinergics can be added if opioids are not effective. The anticholinergics usually use the glycopyrronium or glycopyrrolate. It is the oral absorption of glycopyrrolate is poor, so it is usually given as IV or subcutaneous. And the antispasmodic effect or anticholinergic effect for colicky pain, the usually used dosage is 200 microgram stat followed by 600 to 1200 microgram per day. And it is said that it has fewer cardiac side effects because of less effect on muscarinic type 2 receptors compared to other anticholinergics like hyoscine butyl bromide or hyoscine hydrobromide. comparing to the hyoscine hydrobromide, hyoscine butyl bromide does not cause blood-brain barrier, so it does not cause any toxins. And oral bioavailability is less than 1%. So it is important to note that it should not be given orally. And we can practically we see that if we give orally, sometimes the patient have pain relief. And it is said that this is due to contact with GI tract. And the antispasmodic effect, usual dosage is 20 milligrams stat followed by 60 to 120 milligram per 24 hours, and it can be increased up to 300 milligram per 24 hours. That's the maximum dose used. So the anticholinergic side effects of glycopyrrolate and hyoscine butyl bromide are blurred vision, tachycardia, arrhythmias, dry mouth, constipation, heartburn, hesitancy, and urinary retention, reduced setting. These are the general side effects of anticholinergics. And a few words about organ distension pain is the mainstay of treatment is, if possible, we have to overcome the distension. So in intestinal obstruction, you can give steroid so that the compression is decreased and there will be a patency of the GIT so that the distension may become less. Rice tubes and flatus tube may have a role for immediate decompression in GI tract distension. And vending as ostomies like colostomies or other ostomies may also be used if the pain due to distension is so severe. In the capsular distension of liver, steroids are the mainstay. Usually dexamethasone is the used one. So these are the points which I think I have to convey to you. If a patient has headache, it does not necessarily indicate that he has increased intracranial pressure. And the intracranial pressure due to brain tumor, the better treatment of choice is steroid because the brain tumor destroys the blood-brain barrier. And the opioids have an action on motility of GI tract, and it can reduce the colicky pain. There is a survey going in palliative care formulary regarding hyoscine butyl bromide. So they have reported some cases who had the cardiac side effects like myocardial infarction and cardiac arrest, and hyoscine butyl bromide was given intravenously. So, thank you.
Thank you, sir. Now we are open for discussion. You can ask the questions to Dr. Sunil. Thank you. Dr. Prasad, you wanted to ask something? Can you unmute yourself and speak? Introduce yourself and then speak. Yeah, introduce yourself.
I am Dr. Prasad. I have joined as Associate Professor in Department of Community Medicine in Venkateshwara, Pondicherry. And I have done IAPC certificate course. I liked this discussion and it was very informative. I just missed that part that why mannitol will not be effective after 3 days. No? That part I was not able to hear. So.
Sir, unmute yourself, sir.
This is because after 3-4 days, instead of resting this mannitol inside the vascular compartment, it goes into the interstitium of the brain. So that interstitium becomes hyperosmolar, and this will attract water from the vascular compartment into the interstitial tissue, and this will increase the brain edema.
Any questions? So it looks like everyone is quiet today.
And just for discussion,
Yes.
actually, I told that opioids can inhibit or decrease the peristalsis. So, our in intestinal obstruction, we usually give opioids along with metoclopramide, which increases the peristalsis. So, opioids which decreases the peristalsis, whereas the metoclopramide which increases the peristalsis. So that's just a thought to discuss.
Hello, am I audible?
Yes, Jean.
Yeah, so I had a follow-up comment to that. I yeah, am I audible now? Hello?
Yeah, Jean, speak.
Okay, is this better?
It's far better, yeah.
Okay. Yeah, sorry about that. I had a comment about that. Is haloperidol a better choice than if, instead of metoclopramide? Because I think I read somewhere that it doesn't affect the peristalsis, but it will still have the antiemetic effect, the dopamine antagonist effect.
Okay. Haloperidol is usually used in complete intestinal obstruction. So just now I talked about partial intestinal obstruction, where we increase the peristaltic activity of the intestine so that the obstruction can be decreased.
Yes, John, please talk.
Practice. We see patients and we aren't sure at the initial evaluation if the obstruction is complete or incomplete. Sometimes it's hard to tell from available images or right at that moment. So we'll oftentimes do the trial of dexamethasone. Sorry, was that me? Dexamethasone plus steroids, and see what the response is over 24 to 48 hours as we're trying to support, to augment passage of material if there's a small channel. So sometimes we'll start out with that, hoping to augment peristalsis and decrease swelling. And then we just reassess in 24 to 48 hours. Does that seem to be working, or does it seem to be worsening? And then we might switch then away from peristaltic enhancement. But sometimes we do. Sometimes I can't tell. We can't tell right at the beginning.
Sir, do you want to add something to what John said?
Sorry, it was very, we couldn't hear it properly. So,
Okay.
John, were you saying that ordinarily you would just give metoclopramide, dexamethasone for the first 2 days without metoclopramide, give it a try and add something only if necessary? Was that your point?
My point was sometimes when you first evaluate a patient, it isn't possible to tell if the obstruction is partial or complete. So if you can't tell, it's worth trying both metoclopramide and steroids to reduce any local tumor bulk or the inflammation, tumor bulk, and metoclopramide to augment peristalsis. But if it were to become clinically clearer that it's a complete obstruction, then of course the metoclopramide would cause more problems than it helps. So my point was just that sometimes clinically it's very difficult to tell at first evaluation if an obstruction is complete or partial. So the steroids are always worth a try, and the metoclopramide may be worth a try. But if the obstruction does turn out more clearly to be complete, then you would want to inhibit peristalsis.
How useful would be presence of flatus?
Nandini, I'm not sure that I personally understood your question. What you're asking is if the patient is passing flatus, is that a useful guide?
Is that a useful clinical guide to assume that there is incomplete obstruction?
It may even say that there is no obstruction except possibly it can even be a severe constipation. I mean, in practice, severe constipation is sometimes very misleading. There may be no other obstruction. So that's a possibility. It may not be obstruction at all. I mean, intestinal obstruction at all except by the impacted fecal matter. Or as you say, yes, partial. I should think so. Vidya, do we have time, a couple of minutes more on this?
Yes, sir. Yeah.
John, and also the others, of course, in response to what you said, John, can I tell you what we do and see if you are in general agreement or whether we should revise what should be done? First,
Please.
this discussion is on visceral pain, but in the context of intestinal obstruction or subacute intestinal obstruction, we do not treat pain alone as an entity, we treat the whole problem. Now, if the person already has pain, from the history, I would try to understand whether that pain is colic or not. Now, this is very often very difficult to elucidate. There is obstruction, the patient is vomiting, there is pain, and the description may not be very convincing. If I am in doubt, I'm not basing this on any textbook description. If I am in doubt, I would give, in this context, I would give 10 milligrams of metoclopramide parenterally and see what happens. If it is colic, it's possible that the metoclopramide may worsen. In which case, in my attempt to overcome the obstruction, I would use only dexamethasone. As you said, we don't know whether the obstruction is partial or complete. In advanced malignancy, very often it is partial. So we assume that maybe it is amenable to correction. But we make an effort anyway. We ensure that there is no impacted fecal matter. And then I would try a dexamethasone with an infusion of metoclopramide, trying out 1 milligram per kg per day on the day 1, going up to 1.5 milligram per kg per day on day 2. And in a large number of patients by this time, some oral intake becomes possible and the obstruction may be partially relieved. Now, if the obstruction is not relieved with this, then I may suspect that the obstruction cannot be overcome medically. In which case, I would withdraw the metoclopramide, and then my strategy changes. I accept a total obstruction. I would, unless it really helps with the pain, the dexamethasone may not help. Instead of the metoclopramide, after giving those 6 to 8 hours for the metoclopramide to go out of the system, I would start a gastrointestinal sedative. Because of the cost factor, we usually try iodine bromide first, and anything like that. That's our usual. So here now, in the meantime, we are communicating with the patient and family, helping them to accept that this may be a terminal event, and the best we can do is to keep the patient as comfortable as possible. The advantage of the hyoscine or whatever gastrointestinal sedative or octreotide, if we are using that, would be that at least the incidence of vomiting will come down, and the frequency of vomiting will come down, and the pain will come down. Sorry for the long speech. Would you like me to repeat any part of it?
I could understand clearly, and I think inherent in what you said is start out with a therapy that acknowledges there may be improvement. Sometimes it isn't completely obvious, but start out with a therapy where there may be improvement. If there isn't early improvement, or if it looks like you're aggravating the symptoms, which would be more of a hint of a complete obstruction, then switch to move away from the metoclopramide. So that's exactly what we do, and I think it's a good medical principle to look at the situation and say we may be able to improve it. We can find out without doing any real harm, and then see what the results are of that first therapy. So those things all make good medical sense to me, and are by and large what we do as well. I don't think I have any recommendations to do it any better than what you are. Just good practical medicine.
Gene, I'm not sure that I understood your earlier question. Can you repeat what you meant? You were asking about metoclopramide versus haloperidol, were you?
Yes, sir. I was asking because Dr. Sunil had said something about how with opioids we wouldn't give metoclopramide.
Jean, just speak from the computer.
Is this better? Is this better?
Yeah.
This is better.
Yeah. So what Dr. Sunil was saying something about with morphine you wouldn't use metoclopramide because one is a GI sedative and the other causes peristalsis. So I was wondering whether haloperidol with morphine could be used in that context.
So actually, that question, because even we were thinking that in case of intestinal colic, we tend to use anticholinergics first, instead of thinking that even opioids can cause or decrease the intestinal colic. Here, when I read about this more, it says that you can use metoclopramide along with morphine, because it will reduce the secretion of acetylcholine, but there will still be the peristaltic activity. It is not like anticholinergics along with antispasmodic, which is in which there will be competitive antagonism. So the both effect will be cancelled each other. But when you use morphine along with metoclopramide, there will be action of metoclopramide still will be there.
Jean, is the confusion clear? Sunil was not saying that morphine should not be given with metoclopramide. Sunil was asking a question. They have some possible opposing action should be used, and his answer is they can be combined. Right? Sunil?
Yes.
Dr. Rajgopal sir, I had a question about what you had talked about GI sedatives. Can you tell us what is the GI sedative protocol that you follow there? I mean, you had mentioned octreotide and we talked about morphine. Can you tell us like what is there an algorithm that you follow in case of complete obstruction?
Gene, the algorithm is decided with the fact that I am a conjuice. I keep trying to save money. Otherwise, we would go to octreotide. Now, fortunately for us, octreotide is not as fearfully expensive as possibly in Jones' country. Then it's formidably expensive. But octreotide is still expensive. And as a miser, I try to get away with hydrogen butylbromide. That's the only reason. If I could afford it, maybe I would have gone on to octreotide straight away. Now, I'll let John comment on it later. But what we would ordinarily do is give about 60 milligrams of hydrogen butylbromide a day in 3 divided doses. Or better still, give that as an infusion. About 90 milligrams a day might be the maximum that I might use in a day. Now, if that is not adequate, if the volume of vomitus is still high, then even though I am a miser, I may switch to octreotide. Nandini.
Sir, I wanted to ask, while we are trying to reduce the movement of intestine, we could also reduce the secretion by cheaper methods too, like proton pump inhibitors and antihistaminic. What is your opinion on that? Because that is one of the reasons why there is distension and the pain.
There are two things, Nandini, as I understand it. The hydrogen butylbromide, or let us put this in this hierarchy, octreotide and then hydrogen butylbromide would be far more effective in reducing the GI secretions than your proton pump inhibitors or others. That's one thing. And secondly, their concurrent action in decreasing the motility of the gastrointestinal tract helps in preventing any colic. So the two together, the first one giving us the advantage of decreased frequency of vomitus, and the second one controlling colic.
Sir, can we move on to Dr. Sridevi's case presentation, which is also on intestinal obstruction? Maybe if anyone else has any questions, we'll continue with the discussion after the case discussion. Sir.
Yeah, after the case presentation, Vidya, maybe
Yes,
it
sir.
would be nice to come back to elevated intracranial tension. Yeah, because
Yes, sir.
people would have some practical points about how to go about it. But it's a good
Okay.
idea to have the presentation now.
Okay, sir. Yeah.
Or Vidya, do you want to finish the ICT discussion? And because otherwise it will be switch on or off. No? Which way? Which way you
We'll
decide?
finish the ICT and then go to the presentation.
Um, I have a couple of comments, but that's only after taking anybody's questions or comments about management of elevated intracranial tension in the palliative care setting. Meaning, the typical patient is the one with an intracranial tumor, advanced, with intense headache and vomiting, etc. Questions or comments from the Jennifer, you looked as if you were about to ask a question. So, I mean, like, I put on my anesthetist hat for a minute and talk about
Mary, Sir, Mary wants to ask a question, Sir, Dr. Mary.
I was wondering, can we give oral glycerol in these patients? Even in a palliative care setup, oral glycerol may also be effective in reducing the ICP.
Anybody want to answer that question? Maybe my answer is no. I'll explain why. Among the various options, one of the things that we'll remember here is the blood-brain barrier, as Sunil described, in the myocardial tumor may not be totally effective. It is not as if there is no barrier, but it is compromised. The problem with oral glycerol is that its ability to cause rebound edema is more. Sunil explained rebound edema both in the case of the hypertonic saline and with mannitol. That is, how does it act? You give the mannitol in about a fairly fast, maybe 20 to 30 minutes. It increases the osmotic pressure. Fluid is drawn from the extravascular compartment into the intravascular compartment, then gets excreted, and the brain swelling comes down. This is how mannitol acts. Now, what would happen if after the first hour, slowly mannitol started seeping into the brain cells across the vascular compartment? That is what will happen if the blood-brain barrier is defective. Now, even with intact brain, but particularly with defective blood-brain barrier, glycerol crosses much more. So, glycerol is notorious for causing more rebound edema, which is why specifically we would prefer oral steroids more than anything else. And hypertonic saline has the same problem of causing rebound edema. So those measures are the transient things. Your dexamethasone takes at least 24 hours to cause pain relief. And you can use these measures for that interim period, remembering that a dose of mannitol will act only for about 6 hours or about 8 hours. That's all. Then it comes back. You have to give the second dose. But now that we are making a recommendation for mannitol and getting away with it, nobody is objecting violently. Did you make a note of the dose that Sunil mentioned? Nowadays, I mean, earlier, some 10 years back, mostly mannitol came in 200 ml bottles. Now it comes in 100 ml packs. Now, with our usual regime of what our own pack contains, give it. Usually we give 100 ml, which may be very inadequate. The initial 5 ml of 20% mannitol is 1 gram. And if you want to give half a gram per kg as an initial dose, you can calculate. You would need somewhere between 200 to 300 ml for the initial action. And then subsequent doses can be smaller. So just a 100 ml bottle of 20% mannitol as an initial dose may be grossly inadequate, may not serve the purpose. And shall I make one more point and then shut up? About dexamethasone. I don't know the evidence for this. I haven't really studied. Dr. Twycross's usual teaching I have found to be very useful. You can titrate dexamethasone in 2 weeks. Titrating up or starting at a high dose and titrating down. Sometimes we give very large doses that may be required. We give usually the dose starts with 16 milligrams or you go up to 32. Don't give up. In an advanced malignancy with elevated buccal pressure, Sunil recommended up to 96 milligrams. So you may also, in intense pain, start with a high dose. How will you use 96 milligrams? Maybe as an infusion over a couple of hours. Yeah. Usually not more than 1 milligram per minute. So you give that infusion. And if you succeed, the next day, you try a much lower dose. Maybe you try say 72 milligrams. The next day, you come down to 48. You find the optimal dose. You can find the optimal dose by titrating up, which could be a slower process, or titrating down, which could be a faster process, but with greater side effect profile. I have had one patient who settled down on 48 milligrams of oral dexamethasone a day. She lived for more than 6 months. This patient was being taken home to die, and she was a nurse, and she was brought to us as a last resort to try. She lived for 6 months on 48 milligrams. Unfortunately, she developed Cushingoid features and hirsutism and all, but she lived to see her daughter married. So it can sometimes make remarkable difference. As promised, Vidya, now I should have.
Thank you, sir.
Thank you for shutting.
Sir, actually, when you are mentioning about the slower and faster, no, sir. You were mentioning about the optimal dosage, how to do with the slower and faster process. The volume was breaking up. I think not many could hear what you were saying. Is it possible to repeat that, sir?
I mean, what I said was, when you start at a high dose and titrate down, obviously you achieve pain relief quicker. You do it, and by tomorrow, most patients would have achieved pain relief. If you are trying to titrate up, then you bring up to 24, no pain relief. Next day, you bring it up to 32, and gradually it may take several days to achieve pain relief. because optimal action takes up to 12 hours. So I was saying that titrating up is a slower process as far as achieving pain relief is concerned. On the other hand, titrating down means you are giving a large volume which may be unnecessary, large quantity which may be unnecessary, with all the adverse effects on the side effects, including hyperglycemia. But you know, the side effect that I am most concerned with long-term steroid is something that we usually forget. That's the psychotraumatic side effects. Not only the obvious delirium, but also after that initial period of euphoria, people may go into depression. And those are things that we need to monitor for. Not only the blood sugar and the blood pressure and the skeletal muscle function.
Thank you, sir. So any questions? Or shall we move on to the case presentation? Sridevi, you are ready?
Yes,
Then
Vidya.
we'll do the case presentation. Yeah.
Can you go to the next? Yeah. So this is a story of a 40 years old female who presented with loss of appetite and weight loss to the patient to an adjacent. Is my voice clear?
Not
Am
really.
I audible?
It's breaking up.
Okay. Internet connection is a bit unclear. If it is going unclear, Dr. Sunilkumar, I guess we have seen the patient in the patient unit. So they investigated in the regional cancer center and found to have
Sridevi,
yeah.
Sridevi, it's not at all clear. Maybe Dr. Sunil can take over from here.
Please, please.
So can you do the presentation, please?
So, I'm Dr. Amrita. I'm going to present this case. So, it's a 40-year-old female presented with loss of appetite and weight loss in 2015. She had an adnexal mass with moderate ascites and omental stranding and deficits. So, there were para-aortic nodes and subcapsular deficits. And CA was elevated, CA125 was elevated, and there was metastatic adenocarcinoma in ascitic fluid cytology. She received 3 cycles of NECT. On reassessment, the CT shown residual bilateral ovarian mass, no lymph nodes, and no ascites, and there were no subcapsular deposits. So, surgery was done. Interval cytoreduction was done. So she had a recurrence of symptoms in 2016. The symptoms were inability to eat or drink due to vomiting, and the CT showed enlarged right external iliac node with minimal ascites. So second line chemotherapy was deferred by the patient, and she reported to us for symptom control. So she reported to us with nausea and vomiting for 1 month and was not able to tolerate both solids and liquids. She had constipation, feeling of fullness, pain, and decreased urine output. So on assessment, the abdomen was tense, tenderness was present over the left hypochondrial and iliac region. Bowel sounds were decreased and ascites was there. She had her abdominal pain was a dull aching pain, scoring around 4 by 10. It was an intermittent pain and was not troublesome most of the times. The vomitus was sometimes coffee colored and it occurs with or without food intake. It was preceded by nausea. So she was passing flatus. So pain was as recorded in the chart. The pain was mainly in her left iliac area and also in the back spinal region at the lumbar level. Our treatment was like we were suspecting whether it was partial bowel obstruction, and we started her on injection dexamethasone 16 mg OD along with metoclopramide 40 mg continuous infusion over 24 hours, which we later increased to 60 mg over 24 hours. She was also given potassium chloride intravenously in NS over 4 hours till the potassium came from 2.8 to 4. On her rectal examination, it was found below the rectum and she was given high of enema. She was on tramadol on an SOS basis for pain relief and maintenance fluid were also given. Ascitic tapping was done. She became better with less frequent episodes of vomiting for 2 days and could tolerate few cups of water and 1 piece of breakfast. She was explained why these symptoms happen and what is our plan on how to control it conservatively. Her symptoms were not controlled significantly even after a week. Her bowels did not open. After 2 days of relief, she started vomiting again. So we planned to taper and stop the steroid and stop metoclopramide. Pain was meaningfully controlled. She wanted to try for the second line chemotherapy once she deferred in a hope that she can drink some water without vomiting. During admission, she was distressed mainly because she cannot even drink a drop of water without vomiting. She knows that the disease is progressing, but she finds difficult to tolerate the suffering. She is not married and is the breadwinner for her mother and a differently abled sister. She thought that her disease has been cured and was leading a normal life after surgery. The recurrence has put her down again. Her biggest concern is about her family when she is unable to look after them. Worried about how they survive if something happens to her. We explained her why this is happening, about the disease progression, about the current treatment strategies, and how are we trying to overcome the obstruction. So other psychosocial concerns include feeling of being a burden for the family. She once told that there is no point in being alive without even drinking a drop of water and requested us to end her life. She mentioned that even God did not help her, even after visiting so many temples. Many doctors told her that all this happened because she did not have an active sexual life in the past. This has added on to her guilt. So her main concerns when she came, she wants to drink at least water without vomiting. So any other strategies for better symptom control? Sri, you can add up your comments, please.
Looks like she's not there.
Am I audible?
Yes.
Yes.
Yeah. Okay. So she was sent to RCC for further treatment. She wanted to try one more chemotherapy. Um, she was not very satisfied with the symptom control because she was unable to eat or drink even after getting so many injections and medicines. She told. And at last, she became reluctant to taking injections also. So we sent her to RCC, and she's been admitted there at prison, put in rice tube, and nothing she could tell us. Like for the details, she didn't understand from the doctors. So she told she is admitted with a rice tube. That is the last update from the patient.
So we don't know if the rise tube is helping her or not?
No, John, actually, we could talk to her, not directly to her inside the hospital. So her mother picked up the phone. So we got only this information from that person. She didn't even know why, like whether the doctor is thinking okay or not. Being admitted in a cancer hospital because they have reached somewhere where they can do, they are expecting some kind of.
Dr. Prasad, you wanted to ask a question, no? Okay, you can ask.
The psychosocial issues, how were they addressed? We wanted to know how the psychosocial issues of this case were addressed.
Okay. Sarath is also part of the team. Can Sarath please add on to that?
Hello? Hello? Can you hear me?
Yeah, Sarath, yeah.
Okay. So as Dr. Amanda said, she was referred to her IP for that symptom management and all. So by the time of admission, she was having that hope that from palliative care she will get some kind of relief of symptom. So her major concern was to have at least a glass of water or some food. So initially we were trying to manage that, and we already told her that we are just trying to manage the symptom. and all. And gradually we communicated with prognosis that her disease is progressed and we may not be able to bring adequate symptoms and all. Then her initial concern was about her family. She is unmarried actually. She is 40 years of age, and she was the breadwinner of the family. She has actually got a mother. Her father left her 20 years back, and she has got 4 siblings. The elder one was a brother, and he also left the family 15 years back. So she was the only one who supported the family throughout for the whole 15, 20 years. Actually, this diagnosis was totally unexpected by the family. Her sister got some mental illness also, she's not also able to go to work or some work or support the family. So her major concern was about like what will happen to her family if something happens to her. So her mother is already 70 years of age; she cannot do any work, and her sister is also having some mental psychological issues. So she was really worried about that. So what we did was we discussed like the plan of providing some kind of social support for the family, like we here do like occasion rehabilitation services. And when I discussed that, she was really interested in that, and she said if we can support the family in some kind of way, so that the family will get some kind of income and they will get that adequate social support. She said then I can die peacefully. I'm not worried about that. But yeah, so after that she became calm, and after 4 or 5 days she was able to have some little water and all. So she was actually getting into that acceptance stage that she has very limited time left, and so she wanted to spend the time at home with her family and all. So now also we are still following upon that, and we are trying to give them that occasional training and all. And yeah, that's all.
Yes, Nadia.
Regarding the Riles tube, I remember a patient who had CA ovary itself, and a similar case where she wouldn't tolerate even a quarter glass of water, and she was very young. And she said, I just want to, not vomit, but still continue to have. And I remember when the Riles tube was put, she said, this is the best thing that you could have done to me, because she was no longer vomiting. So, I mean, it made me think as to, we look at avoiding Riles tube for all patients, but if all our combinations and cocktails don't work, sometimes we do. I don't know whether we should consider Riles tube as, of course, nothing was reaching her body because it would go and then it would be aspirated out of the Riles tube. But she had the satisfaction of actually gulping in the water and not having that terrible feeling of, that nausea and vomiting. Of course, another option, if it is possible, is a venting gastrostomy also. But I just wanted to present that, Riles tube, should we take like the failure as it is normally seen in palliative care viewpoint, or should that also be an option in such patients who are completely having intractable symptoms?
I wanted to support that idea. As the case was being presented, I found myself thinking that given the description of her symptoms, the venting gastrostomy tube or a rise tube sounds like it has more to offer, even with the initial discomfort of putting it in and the ongoing discomfort of having it down. I too have had patients, just as you described, who have said, thank you for doing that, for putting that tube in. It isn't for everybody, but I think a conversation to ask her, is your life significantly better with this tube in? She'd be able to make a meaningful answer to that question. And if it is, well, it may allow her to do the things that you just described, Dr. Nandini. So those were my thoughts going along there as well. In a minute, I'm curious about some other things that were said about here, but let's stay on this pathway for the moment. Do other people have comments about that?
I would agree completely with what Nandini said and what John said. Absolutely. I mean, not having a right suit should not be a religion. And some people absolutely need that nasal tube. And there is a specific indication. Now, one of the kinds of pain that you have in visceral pain is the pain of distension. What medicine will treat that? Nothing may be effective till you relieve the distension, wherever it's in the body. So, if it's a gastric distension, and that will be a marvelous way of relieving that distension, just as a flatus tube may help in the case of a distended lower large intestine.
Can I say add on something to that?
Yes.
Am I
Yes.
audible? Yeah. So her vomiting was very similar, like small spits, always in a full every time. It was never high volume. The symptoms were not like she was feeling full, then taking relief by vomiting. Always in a very mild condition. I don't know whether I was audible. Sorry.
Your voice was breaking, but you were saying, I think we heard you say that vomiting was never a large volume vomiting. And I would tend to agree with you, Sridevi. The patient whom you described may not have been a good candidate for an nasogastric tube, and that may help or may not help. I mean, we were only generalizing about the value of a nasogastric tube, not necessarily in this particular case.
And this patient want to take orally. That was her wish, not the rails tube. I also agree with what Dr. Nandini and John told. And even I had a patient who want to take something, but not necessarily orally. So this patient had vomiting. So we put a rails tube, and it was the rails tube bending was done. And after some time, we give it. He takes orally through the orally, and he will that will when the quantity becomes more. When it distance stomach, we will open the rice tube again. The drainage will be done. So in that way, the patient was satisfactory. So, but this patient's wish was to take it orally. So that's what she wanted.
I really agree that I agree with what Dr. Sridevi said, that sometimes with this spit or things like that, maybe that person isn't classical vomiting that you might see with an obstruction. But I don't see anything else to try here. I see at least a potential of, when they were thinking about putting in, I see at least a potential of significant benefit, and I see relatively limited burden. It is uncomfortable to have that in place, but if you frame the conversation with the patient that there's the potential of significant benefit, then you can see if it helps or not. There's the potential for distress from having the tube down, but you can tell in a few days, is it better or is it not better? So I go back to, I think that was an excellent idea. Like Dr. Raj said, she may not have been the classical kind of bilious, high volume vomiting. Nonetheless, this was worth it. I think it was a great idea.
Thank you, John. We will move on to the next case presentation by Dr. Jean. Jean, are you ready to go? I will summarize and send the summary by email if you don't mind. The time is up.
Vidya, maybe Dr. John had one comment to also give us after this particular point is discussed. John, do you want to give that point?
Yes, sir.
I don't want to take up too much time, but I wondered as I read the spiritual history that the sentence, many doctors told her that these things happened because she did not have an active sexual life in the past. In my experience, I wondered if that was accurate or if that was a misprint in the U.S. I think many doctors could be judgmental about a woman having an active sexual life in the past just on a judgmental cultural and gender basis. Did doctors really tell her this would have happened because she didn't have an actual sexual life? Because again, it would be just the opposite in my experience. Any comments? Am I saying it clearly?
It may be more likely that the doctors, giving them, like telling the facts of things as to the incidence of breast cancer, when does it happen, and where probably that instruction, the information given was in such a way that she understood it to be sort of, directly accepting that as the cause of her issue. It could be that way. It's very, very unlikely that, I don't know, it might have, but it is very unlikely that they must have said, you got this because of this. Because it's mostly probably an interpretation. That's what I feel.
Okay, that's a good answer. As I read the case, I found myself thinking, oh no, another doctor has said something like this. So enough time, but I was curious as to others' thoughts. Thank you.
Doctors often say these very clinical facts, including even smoking. Like somebody may have smoked and then got lung cancer, but when somebody is nearing the end of life, there is no sense in bringing that up 7 times a day and reinforcing guilt. Similarly, as Nandini says, it was a clinical story and presented that way, which is of no consequence, no positive consequence, and only of negative consequence. And Jean, I think, earlier asked, how were the psychosocial issues, psychosocial-spiritual issues addressed? I don't know exactly, but because Sridevi is not clearly audible, I would only say what I am not sure what was done, but I would still, in a minute, say what I would do. The most important thing is to sit down with the person and listen to her and allow her the opportunity to ventilate her feelings. Try to, in the process, maybe try to reduce that burden of guilt that she is carrying. And I am sure Sharath and his team would, as her in the future, see what kind of social support can be offered. At the bare minimum, Dean, we have a food kit program, at least for the starving people. Even the promise that we are not going to desert your mom and your sister. We are going to do at least this. If they do not have enough food, they'll get a kit from us once a month to prevent them from starving. Even that will be a great spiritual support. Naturally, I would say that only if I can keep that promise. But I think in this case, that kind of thing is more important than all the pharmacology that we are discussing. Allow her to feel cared for, feel that she is not deserted by us also. She is feeling that God has deserted her. And just conveying that someone cares is so very much important.
Sorry, Vidya, now you can actually move on. Sorry.
Yeah. Thank you, sir. Actually, this question was asked by Dr. Prasad from Pondicherry.
Okay.
And thank you for clarifying, sir. Yeah. Jean, we will go to your presentation now.
Thank you. Am I audible now? Okay.
Yeah.
Okay, can we go to the next slide? So my name is Jean Jacob. I'm presenting from M&J Hospital in Hyderabad about one patient we saw in our adult OP department. This is a 56-year-old male patient who was diagnosed with cancer of the right lung. At the time of diagnosis, the diagnosis was made in January of this year. He presented with an advanced stage of the disease. It was already, the disease had spread to the brain, the liver, and the adrenal glands. So from the medical oncology side, he was planned for palliative chemotherapy on a daycare basis, and he was referred to the palliative care department for pain. So incidentally, the patient is also a known case of coronary artery disease, and angioplasty was done the previous year. Next slide, please. So it was a severe pain in the right side of the abdomen. It was poorly localized, and we tried to elicit some descriptors about the pain, but the patient was kind of vague at that time. An 8/10 pain. It was aggravated by movement and relieved by lying on that side. And the sleep was also disturbed because of this pain. So we initially thought it was a visceral pain, maybe a liver capsule or the adrenal gland, or because of some perihepatic nodes, that could be the reason for the pain. The patient at that time could ambulate with some support, and was normal bowel and bladder habits. Next slide, please. So these are the investigations related to the chest X-ray and the ultrasound abdomen. We just were able to confirm that it was a non-small cell lung cancer, poorly differentiated. On the bone scan, there were no skeletal mets. Next slide, please. So the first day that we saw this patient in the OPD, we started, as per the WHO analgesic ladder, we started for severe pain on tablet morphine, and we started on step 1 paracetamol, and we used an adjuvant dexamethasone at a low dose. And now after the discussion we had, I feel we started from the low end, and maybe we could have started from the high end. So we started 8 milligram, just a trial for 5 days, and we asked the patient to review again. Now this became challenging for us because this patient lived a little out in the outskirts of Hyderabad, and because of the patient's mobility issues, from the next time it was only the son who came to the OPD, and so we had to kind of, sorry, can we go back to the previous slide? Yeah. So the second week, it was the son who came and told us that the pain is still persistent. So we increased the dosage of the morphine. And next slide. So because it was only the son who was coming once a month just to collect the palliative chemotherapy, that was when our contact with the patient was happening indirectly. So the second month, the son came to us again and said that the pain is persistent and there is daytime drowsiness. So we thought that maybe it is not responding, or an opioid non-responsive sort of pain. So we advised whether they can be admitted in our hospice facility, or if not, then to bring the patient to the OPD, but they were not willing for either. So we increased the dose of the morphine to 30 milligram Q4H. The third month, that was last month in May, the patient came, the proxy came, the son came and told us that there's end of dose failure. Basically, for 2 hours after taking the tablet morphine, you get the patient gets pain relief, and after that, it stops working, and the patient again is drowsy. So the last time we saw her, maybe saw him a couple of weeks back, we increased the dose of morphine, and we decided that if the patient is far away, we are not really able to treat him in this way. So we planned a home care visit to go and see the patient. Our nurse and counselor went and wanted to directly see what was going on. Next slide, please. So the nurse, after the examination, had told us that it was a right flank pain, very severe, still persistent. Patient is drowsy with morphine. We coincidentally, this was also the time last month when we started. We got a methadone license, and we were actively looking at whether we can start methadone in our patients who were not getting opioid responsive, who are not very well responding to morphine. So thinking along those lines, we checked the medications that the patient was on. The patient was on ecosprin, statins, clopidogrel, and we advised for a baseline ECG. The discussion we had among ourselves was that either we would see if the patient is an ideal candidate for methadone, or maybe rotate opioids to the fentanyl patch. Next slide, please. So the patient, just briefly, I'm going to talk about the psychosocial issues. The patient was aware of the prognosis. He was his most concern was about his family, his 3 kids, and the fact that he was not able to ambulate and get along to work as he used to before. Next slide. So initially we thought we would talk about methadone, but before that there was just some other things that we wanted to discuss. The role of other adjuvants. So when we were reading up about visceral pain and the adjuvant therapy for visceral pain, we read about the role of octreotide, about baclofen, and even SSRIs and TCAs are purported to have some role for visceral pain. And then there's the role of nerve blocks like the celiac plexus, hypogastric plexus, splanchnic nerve plexus block. So we just want to have a discussion on what are the adjuvants, what is the role of these adjuvants, and is there any sort of algorithm for visceral pain management for this sort of patient? Thank you.
Vidya, before you go on to the discussion, can I clarify something with Jane?
Yes, sir. Yeah.
Jane, what I mentioned about starting with a high dose and titrating down, thank you for mentioning that, because I would have ended up conveying a very wrong message. That is valid only for elevated intracranial pressure in an advanced incurable disease. That is not valid here. Here the dose to me would be still 4 to 8 milligrams, not those 96 milligrams. And that dose, let me repeat, is valid only for elevated intracranial pressure. For a spinal cord compression, you may use something in between, maybe 16 to 32 milligrams. But for everything else, lower that.
Thank you, sir, for clarifying that.
Okay. Can we unshare the screen?
Sure.
Can we stop? Yeah.
Is there a role for local radiation?
Vidya, you were saying something? Unmute yourself.
Is there a role for local radiation palliative RT because it was localized flank? So was it the rib or just localized radiation in that area because she was drowsy with morphine and knowing that it's non-small cell, lung, and was local radiation ever thought of palliative RT?
I found myself wondering what it is that you're actually treating on this patient. The notes that this relates to the question about radiation too. It said the bone scan was negative, if I'm correct, and so it's likely not a possibly not a bone pain issue. I saw that in the history, there adrenal metastases were noted, and I found myself wondering, is there an adrenal metastasis on the right that could be causing this pain? And so I don't know. Don't know the reports. Maybe is it a right adrenal metastases or bilateral adrenal metastases? I found myself wondering. Pain was described in the severe pain in the right lumbar region initially, and I thought, well, what could cause that? And then the description of the flank pain also. Actually, a kidney stone crossed my mind. In light of the negative bone scan, I found myself wondering, when you talk about the right lumbar pain, could this be paraspinous muscular pain, not cancer-related pain? So far, I don't have any answers, but those are the things that were crossing my mind about what is it that we're actually. When I thought about those things, I thought about, would something like a lidoderm patch, if that's available, or any kind of topical, if useful if there was a very focused pain on the right side. Another thing that crossed my mind, and again, I'm just throwing out a lot of options here, if this was musculoskeletal pain, again, where it's described as right lumbar, or even if this were felt to be from an adrenal metastasis on the right, could potentially non-steroidal medications have any role in this? So those are the things that were crossing my mind. I threw out a lot there. Let me mute here and see what other people think.
Yeah, John, your voice was breaking in between, so I couldn't catch part of the questions. At the beginning part, you were asking about the adrenal mets. So we were thinking about that as well, because there was right adrenal mets. So we were thinking it might be related to that. But then we didn't know, even if that were the case, whether there was anything specific we could do for that.
Well, I think your idea of steroids and opioids is a good idea to try to treat that. Again, I wonder, I think about NSAIDs as being, if these other things aren't working, both their anti-inflammatory and their analgesic properties, just empirically to see if that made a difference. Especially if it could be musculoskeletal pain as well, non-cancer related musculoskeletal pain. But I think you did exactly what I would have done to start looking at opioids and steroids. I'll mute now.
I had a question about steroids for this, because we've been talking about steroids a lot today. So I want to know, in this kind of scenario, what we did was we tried a low dose of steroids, 8 milligram, and we tried it for 5 days, and we didn't find any relief, so we stopped it. So I want to know whether should you step it up? Should you keep going for more an extended trial? What would be the evidence on that?
In my experience at that dose, and again, that me, that's a meaningful dose in this situation. Like Dr. Raj said, you wouldn't do the 32 milligrams or anything like that. So that's a dose that I would use in my practice in this situation. And I agree with you that if there's no results after 5 days, I think you give it a fair trial. So I don't have anything different to offer in that setting. What do others think?
Yeah, the dose of steroids keep varying based on the situation. So what we talked about for ICT is very different And for visceral, when you're looking at capsular enlargement or something like that, I think 12 is the 12 milligram max, not more than that. So you were already giving 8 mg. And generally the trial is given for a week. And so all the stepping up and everything is done within the week. And if that doesn't show a response, it is required by us to stop it. All that I would have suggested is maybe you could have stepped it up to say 12 but I don't know how much, if 8 did not have any response at all, I think it was fine. But NSAID is definitely something I would have thought of in this patient that might have helped. Sir, do you want to say something, Dr. Ash?
No,
About the dose of steroids that Jean was saying, he gave 8 mg for 5 days. Was it inadequate? He was asking.
no, I think you already answered that. I would agree.
One question I had, sorry, please.
I was just going to say that although we don't necessarily think of non-steroidals as being a first-line drug for visceral pain, the drugs that you have tried for visceral pain, with still a little bit of uncertainty about the exact cause of the pain, could be the adrenal mets, could be non-cancer musculoskeletal. Even though I don't think of the NSAIDs as being a first-line drug for visceral pain like this, it does seem like it has a high degree of safety. There are potential problems, of course, with NSAIDs, but a relatively high degree of safety, relatively low degree of toxicity, and a fairly fast window of seeing if it would make a meaningful difference. And then if it made a meaningful difference, you'd have to think through the process. Is the risk or burden? Sometimes we talk about burden of treatment, but here it's a little bit risk of treatment. Does it outweigh, does benefit outweigh that burden? So that's how I would look at a trial of an NSAID. I hope you can hear me okay. Thank you.
Can I ask a question?
So, yeah, can I ask a question?
Yes, Jean, yeah. Yes, Jean?
Sorry. Yeah, I just want to know, is there a role for other adjuvants like the SSRIs or tricyclic antidepressants or alpha-2 agonists? Because when we were just reading up on generally for visceral pain, they mentioned that these medications which we normally consider for neuropathic pain, they even have a role for visceral pain because of the neurotransmitters involved are similar. So they have a role. So I just want to know if there's any experience using that for visceral pain.
Does anybody want to answer that question? Were you going to say something? Jean, I totally agree with you that a neuropathic process could very well be relevant for an intra-abdominal malignancy, and with the difference is the difference being that the manifestations will not be discernible. If it's a peripheral, somebody needs to mute the microphone. Now, if it is a peripheral, it's a pediatric palliative care unit in action. If it's a somatic neuropathic pain, you would find symptoms like the burning kind of pain. You would be able to identify a distribution. Now, these things may be totally lacking in a visceral neuropathic pain. So, with difficult pains, if they are not colicky type, if they are not distension type, if they are difficult to control, we might still try a tricyclic. Now, in answer to your one part of your question, if we are trying a drug for neuropathic pain, it would indeed be tricyclic, not an SSRI. The serotonin specificity is not an advantage there, not an alpha acting drug, because the alpha adrenergic specificity is not an advantage there. So the choice would still be tricyclic, not an SSRI, not an alpha adrenergic agonist. Okay.
Yeah, mate.
I was just wondering if we could even add an anticonvulsant like pregabalin, because it's possible that some nerves could be entrapped, and I think there may not be any harm in adding an anticonvulsant also, because sometimes we've done that for patients with pancreatic cancer, and I'm not sure, but I thought I was just suggesting, thinking of them.
Maybe in a neuropathic pain, whether it's somatic or visceral, what I would do is to start with one, either a tricyclic or an anticonvulsant. Build its dose up to an optimal level as tolerated, and then consider adding another one. So, in the case of an intraabdominal malignancy, where there is a suspected neuropathic pain, which cannot be easily diagnosed, you want to empirically try something. It could be either a tricyclic or an anticonvulsant. And I, being a miser, would try tricyclic first.
Yeah, John.
To my mind, there's a bigger, there's another issue here. And it's the science behind what we do, and it's the intersection of science, evidence, and thoughtful empiricism. I think as palliative care grows in its breadth and integration, whether it's in India, in the US, or wherever else, we have to be able to explain to our colleagues, what is our rationale for doing this? And again, I think that Gene and his team have sound scientific standard of practice, evidence-based approach to the things that they've done so far. When a person doesn't get relief from having done those things, then I think we have to be able to articulate to our colleagues who want to know more about the scientific basis of palliative care, about why we're choosing to do what we're doing. And again, when we leave the realm of solid, gradable evidence for what we're doing, then to my mind, we're in the realm of thoughtful empiricism. And in all the comments that I hear my colleagues making here, it's the underlying rationale is it's possible that it's this. It's possible that it's nerve pain. It's possible that it's an atypical presentation of a nerve pain. And again, when we start doing some of these other things, I urge all of us to be able to say to our colleagues, to our students, we're doing this because the most scientifically proven treatments haven't given relief. There's a thoughtful rationale for what we're doing. We're treating what could be an atypical presentation. And we've weighed burden and risk versus benefit and have looked for a meaningful response. So I think, to my mind, it's a good idea, and we do this with our students, residents, colleagues, everybody else, are able to articulate what we're doing and why when we've stepped into this realm of thoughtful empiricism trying to help patients. I hope that makes sense, but to my mind, it's an important thing as we develop how our practices are seen and integrated. Thanks.
Thoughtful, what, John, with that word escaped me. Thoughtful?
Empiricism.
Temperate.
We joke that we never descend into mad empiricism. It's always thoughtful empiricism.
My thought goes, it's similar to what John said, but I was wondering, Jean was getting information once a month from visit of the sun, and I don't know how this could be, further improved, accepting the fact that he stayed away and he's unable to move. Some of the things that we have found useful was, of course, calling up home, talking directly, not necessarily only when the sun comes, but also in between, talking directly to the patient. We know the picture directly, because when someone speaks to another and the another is reporting, things may change the way they present. So a direct information from patient. Nowadays, so many of them have smartphones. You may even be able to, see them. That is one possibility. Another thing is, can there be a connection between a local nurse or a local practitioner who can come home and then report to you from there? Again, so that may be a little more informed report. So instead of just depending on 5 minutes of visit by the sun, because we may understand the picture of pain and the discomfort and the whole picture much better if we have access to the patient in other ways than just once a month. So, we are not restricted. Here, so much of like we are talking about this maybe and that maybe some more information can help us understand how to move forward.
I have a question to Jean. Jean, when was the bone scan taken? Because there seems to be a gap of 3 or 4 months. Meantime, maybe he developed the bone met. Did you take that into consideration?
Yeah. Hello. Yeah, Dr. Vidya. Yeah, the bone scan was done sometime in February. So the patient presented in January, and the bone scan was done sometime in February. But yeah, we have not repeated it since then. So that is a possibility we didn't consider. And I just want to respond to what Dr. Nandini was saying. We also totally agree with that, because of the kind of logistical issues. We weren't able to totally connect well with the patient as we would have liked to. We were working through a proxy, and whenever the sun came, the sun would call the patient, and we would talk to the patient. But that was it. As Dr. Nandri said, it was like a 5-minute interaction, and then we're like, okay, this isn't working. Let's escalate the morphine and try again. And then we would encourage them to come more frequently, but they would only come once a month. And that is why we eventually decided that we needed to send someone there to kind of see what was going on. So moving forward, we will try to at least maybe 2 weeks to send a team there just to follow up and see how we can help better.
Vidya, Mary wants to say something.
Mary.
I suddenly remember a lot of these things could be mixed pain. It doesn't have to be compartmentalized to somatic, visceral, and neuropathic. It could be somatic, neuropathic, visceral, neuropathic. So definitely, I think the neuropathic element should also be handled in addition to just plain visceral. I think maybe that would give some relief to this patient.
I really agreed with what Dr. Nandini said as I was listening to the case. And Jean, I know what a disadvantage your team is at in terms of that patient not being here. But I recognize my own tendencies. And when we have residents on our service, the resident might say to me, or the son might say to you, the pain is keeping him from moving. And, you know, I've sometimes found that the pain that I envisioned in my mind, maybe it was capsular pain from his liver mets, or maybe it was this back pain or flank pain. But until you really know for sure from the patient, you get this thing takes on a life of your own in your own mind. I'm thinking about the pain. And it's, wait a minute, I'm not entirely sure which pain this is, and it makes a difference. So Jean, you are at a disadvantage, and Dr. Nandini's suggestion about connecting and really clarifying what that pain is really good ideas. The other thing, I don't know if it would be a meaningful value. I don't know if lidocaine patches are an expensive or inexpensive addition to use of resources for his pain, but it did cross my mind that might be something that helped if you thought this was bone pain or some kind of musculoskeletal pain or just local area pain. Right? So those are my thoughts.
Just for academic discussion, we over here we were thinking of we've got access to methadone now. We've got a license and we've got stock in the pharmacy. So we're actively looking for patients that have difficult pain not relieved by morphine, maybe mixed pain, as Dr. Mary was saying. And is there a role for methadone, not in this specific patient, but patients like this? And if so, how do we evaluate a patient that we are considering starting for methadone?
Yeah, John.
I think it can be, again, maybe yes, maybe no with this particular patient. But my thought process is, although no one opioid is inherently better than any other opioid, it does happen that sometimes, as an idiosyncrasy, people will respond to one opioid and not to another. So I think in terms of talking to the patient and talking to your colleagues, if you were convinced that you were treating pain that you hope is responsive to opioids, you could preface your conversation with patient, family, and colleagues by saying that, one isn't inherently better. Of course, scientifically, that methadone is different. But I think that's a perfectly valid basis to try an opioid rotation. In this particular patient, from my point of view, clinically, personally, I would try NSAIDs first. But that's just my clinical take on the situation, and I realize you were asking in general. But to be able to say to patients and colleagues, one's inherently no better than another, but sometimes idiosyncratically is better, is a reasonable approach. What do others think?
Yeah, I think opioid rotation is a good idea, but I agree with you, John, that non-steroidal anti-inflammatory would be a very easy thing for Jean to try, as we give the response so definitely and quickly, and he will know whether it's useful or not immediately. As we are going in academic discussion, I was also wondering if we could have had a better picture of his pain, whether, and if we had the right expertise. Like as Vidya said, suppose there is a single rib bone mets or one or two ribs bone mets, some interventional pain management could be, I'm not talking about this particular patient, but such similar patients, pleural, or string of blocks there. These are some of the things we don't discuss at all, but where there is enough expertise, In visceral pain, of course, we should think of, if it has not gone into both parietal areas and surroundings, etc. If it is within the viscera, it is always something that we can do. We should not forget that as an option in visceral pains. So I just wanted to bring it up since we moved on from the patient to possibilities. Any interventional pain specialist here?
Hello.
Yeah, Dr. Mega.
Yes, I've been practicing interventions too, along with the palliative care. And I think if the pain in this case is majorly, if we think it is from liver itself, or not exactly in this case, because we're not really clear that if the patient is actually having just the intra-abdominal visceral pain itself. So, but in cases as in where pain is majorly from liver or the gallbladder or pancreas, in those cases, celiac plexus neurolysis or bilateral splanchnic nerve block, they work really well. So this could be definitely one of the things that can be offered to such patients who are opioid non-responsive.
Thank you, Dr. Bekam. And I think the most important part of using interventional pain management is patient selection.
Yes, yes, definitely.
So we should use it only for the right patient, where we, of course, after giving a diagnostic block with local anesthetic, making sure that that block works, and then we move on to the interventional actual neurolytic agents. But all that is a separate discussion. Vidya, are we having something on that? We are not, right? This particular series, I don't think we have one, but I think we are following this up. This Treat This Pain eco is ending by the next session. That is by middle of June, this session will be over. But most probably, Sunil, please help me in this. We are most probably going to have, I think, multimodal pain management, which will include all the other aspects except medicine. I mean, not pharmacology, but all the other, like, physical aspects, physical measures to treat pain, psychosocial measures, and interventional. We're going to probably have few sessions. So, Sunil, we are in the process of planning, and we hope to talk soon, Sunil. And so maybe at that time, we will probably have 3 or maybe 4 sessions on just, how to use, not actually the technique of using interventional pain, but when to use it, what are the red flags of, not doing it, and, those kind of, at least for a general palliative care physician to know when to refer and when not to refer for interventional pain. So Sunil, please complete this statement.
So it's in the planning stage. So we will inform you once we are ready for next echo. That's all what I can tell you now.
Yeah. So we will hopefully have it sometime. So Vidya, any other questions or comments on this? Vidya, Vishwanath, we didn't hear from you at all today.
Nothing, sir. It's about it was disconnected in between, sir. Internet was gone, so again switched it off, switched it.
Okay, then Vidya, we'll conclude and Vidya?
I have an unstable internet connection today, so it's freezing up. Can you please complete the session?
Yeah,
Sorry.
it's fine. I mean, it was, I think, very interesting discussion today. I learned quite a bit. I hope we will be able to put together the different recommendations on the management of cases, as well as Dr. Sunil's talk, along with the comments that followed in a nutshell, and send it to you by this evening or by tomorrow. Thank you so much. I think all of you all have been with us through so many months of this eco, at least 4 months now. And next will be the last session. Please complete those feedback forms, because it's so important for us to know. This is the first time we are holding a virtual regular session like this, and we really want to know where we started and what happened. Has there been any benefit at the end of this, the whole journey? So please send the feedback forms to Vidya, so that we can do the next session that we are planning. We said is multimodal pain. And so anything is there which can be improved, we will definitely try to incorporate and do better. Thank you so much. Have a nice evening.